Today we have Maria Cristina Ospina is a movement disorder neurologist in a private practice as well as an assistant professor of clinical neurology at the University of Arizona. Dr. Ospina earned her bachelor's degree at the University of California. Her doctorate.
All of that.
We can jump right in.
You can just say I'm a movement disorders neurologist here in Phoenix, Arizona.
Just know though her mother would want her to say all this.
Oh, really?
Her mother would want you to know the accolades. So let's get started. The first question that kind of came up a little bit is about protein and carbidopa levodopa. This came up earlier with, is it 30 minutes? Is it an hour? Can you tell me a little bit about that? You know, the protein.
So remember that your gold standard medicine is still Sinemet or carbidopa levodopa, and that levodopa turns into dopamine in the brain, exactly the same chemical that those little neurons are no longer able to make in the brain. And to get it into the brain, we have to give it to you as levodopa, a precursor of dopamine, because dopamine doesn't cross the blood-brain barrier. So when we give it to you as levodopa, then it has to take a little elevator from the stomach into the brain to get in there. And then the reason it has carbidopa there's two enzymes in the gut that kind of chew it up before it gets to the brain. So we can block one of those enzymes with carbidopa so that it doesn't turn into dopamine in the stomach and cause the nausea and vomiting that some patients get. So that's why the carbidopa is in there. And then the other enzyme that we can block is COMT. And that's why some patients take entacapone or Comtan or Ongentys or opicapone. That way we're blocking both enzymes. And so that more levodopa makes it from the gut into the brain. Right now, of your yellow Sinemet, your carbidopa levodopa, it's only 1 to 5% of that levodopa is actually making it from the stomach into the brain. It's almost nothing. And it turns out that that same little amino acid transporter, think of it, that's the little elevator that gets it from the stomach into the brain. And, it competes with things like protein or, the other, levodopa, when you don't block COMT, it turns into something called 3-methyldopa, which also competes like protein does for the little elevator that goes from the stomach into the brain. So we like to block both of those enzymes. And again, that's why we use medicines like Ongentys, and Ongentys is a much better form of a COMT inhibitor than entacapone or Comtan, because you only need to take it once a day. And we like to use once a day medicines in Parkinson's disease because Parkinson's patients have bradykinesia, or slowness of movement. It's the reason when you go to your neurologist, they have you do this little test and then tap your fingers and toes, is that we're looking how slow are those movements. And remember that bradykinesia, it translates into all of the muscles of the body, including the muscles of the gut. And because the gut moves slower, you get gastroparesis, or a slowed gut, and you develop constipation. More fluid gets sucked out of the stool gets hard, and you get constipated. And once you're constipated, that gastrocolic reflex doesn't work. So that when you eat something like a meal or you take a pill, you swallow it and it goes into the stomach, and it should transition from the stomach into the small intestine, where both your food and your pills are actually absorbed. If you're constipated, that transition is going to take longer than 30 minutes. So it could take an hour, sometimes 2 hours. And that's why you notice a delayed on, that you took your pill and it sat there in the stomach and it didn't kick in. And so if it's sitting in the stomach, it might as well be sitting on your kitchen counter. And so that's why we want to be really aggressive in treating the constipation. And that's why we want to use once a day medicines or longer acting forms of medicines like Rytary or longer acting forms of levodopa, so that we don't need to make that transition from the stomach into the small intestine so many times. And then we don't have to worry so much about the protein in your food. So in the old days, 20 years ago, when we didn't have COMT inhibitors, we didn't have once a day adjunct medicines of any kind, you just had levodopa and you were taking it every 2 hours, then it was really critical when you ate, because that protein was going to compete with that little elevator from the stomach into the brain for that levodopa getting up there. So you would notice, oh, I took my pill and I ate lunch at the same time. if the protein in your food got into the little elevator first, then you would notice that not only did you have a delayed on because of the gastroparesis, but it might have taken an hour or two for that pill to kick in because all that levodopa was sitting there in the gut and not reaching the stomach. So we would tell patients, you should take your pill 30 minutes before you eat or 45 minutes after you eat. But that made it really difficult for patients to figure out when to eat and what to eat. So like they would just wait and take all their protein at night. And so that made everything very complicated. So today, when we have once a day medicines, it's the reason why your doctor, let's say they'll switch you from taking a dopamine agonist like Mirapex or Requip 3 times a day to just once a day, is not that we're picking the most expensive drug out there in the pharmacy, is that we're trying to pick medicines that work better with your gut and that work better, like you work with the way the normal brain gives you or delivers levodopa, a longer acting form. So that's what, so today, the protein is not so critical, but if you are taking your levodopa 3 hours or less, then you want to take the pill first. So it gets in the little elevator first and then eat afterwards. And then if you wanted to, you just use the protein at night. But today we shouldn't have to make your life so complicated. Our job as your clinician is to divorce you from the Parkinson's disease, not have you wake up and every minute of the day, you're planning your day around your Parkinson's disease. We want to use longer acting forms of levodopa and once a day medicines. So it doesn't matter and it's not so critical of what you eat and when you eat. So any other clarification points that you guys want about protein or the gut?
Someone did ask, isn't levodopa an amino acid?
Yep. So levodopa it's a protein. It's made of a little amino acids. And so think of the amino acids are little building blocks of the protein. And your food is made of little building blocks called amino acids that make the proteins. So they use exactly the same transporter. Think of exactly the same elevator to get from the stomach into the brain. And so that's why you see that competition. So that's why we like to block both enzymes. And then get more of that levodopa up into the brain. We want more than 5% of that levodopa to turn into dopamine in the brain and make it work better for us. And that's the reason we use longer acting forms of levodopa, so that we have a little bit more leeway, that it's not so critical about what you ate and when you ate it. You don't want to be always planning your day around what you're doing.
And there was a question about, as you talked about longer acting, isn't there going to be a new formulation for Rytary at the end of this year?
Yep. So right now it's June 5th. So the PDUFA date for IPX203 is June 30th. So it's a new version of Rytary that's going to last about 6 hours. And if it's approved by the FDA at the end of the month, then we should have it available in the pharmacies and in your doctor's office by August. And it would be a longer acting form of Rytary. Right now, out of Rytary, you get about 4 to 5 hours. And we should get a little bit 6 or plus more hours out of every dose of whatever they're going to call it. It only has a number right now. But why is it important to use longer acting forms of levodopa? We're going to prescribe that, and your insurance company is going to come back to us and say, oh, you need a prior auth. And really, we want your patient to be on the generic Sinemet. And so what's the argument we give to the insurance company of why I think it's worth it to be on the longer acting form of levodopa is exactly that gastroparesis that we were talking about, that we don't want to compete with the protein in your food. We don't want you to peak and trough so many times during the day. So if we can get you more on time per dose, that means that you're going to have more control over your disease, more predictability over your symptoms, and that you're not going to be planning your day around every single dose of levodopa. So the half-life of levodopa is only 60 minutes. When we add carbidopa to that, it's 90 minutes. So once you're not making any of your own dopamine, all of the dopamine is coming from the pill, and we're at the mercy of the metabolism of that pill. So after an hour and a half, maybe 2 hours, there's no more dopamine, we have to take another dose. And again, you peak and trough. And so that every time you peak and trough, you go above and below that therapeutic window. And anybody who's had Parkinson's more than 5 or 6 years notice what they call wearing off. So initially, when you first start taking medicine, you don't notice. You could miss that noon dose. You could have a hamburger for lunch and nothing happens. You're like, everything was fine. And why is that? So by the time you come and see your clinician with your motor symptoms of PD, that's things like tremor, although remember that 50% of PD patients never develop that classic tremor, bradykinesia, that slowness of movement, rigidity or stiffness, always that bradykinesia, that slowness of movement, and that rigidity is always worse on one side than the other, and trouble with gait and balance. You've already had Parkinson's 10 or 15 years. So it takes about 60 to 70% of cell loss of those dopamine producing neurons to die off to develop those motor symptoms. So that means that when you arrive at the neurologist office with a diagnosis of Parkinson's disease and they give you a prescription for levodopa, you're still making a lot of your own dopamine. And so when you take the pill, you're basically absorbing that levodopa and using it for later. So think of it that you come into the clinic and initially you've got a savings account of dopamine, which is the dopamine that you're still making. And then the doctor's giving you a checking account of dopamine. And so that even though that levodopa only lasts 90 minutes, and if you're able to buffer it and use it for later, then you don't really notice that wearing off. But once that pill wears off, that overdraft is taken from your savings account. And after 5 years or so, 5 to 6 years, that savings account is all depleted. Those neurons have died off and they don't produce any more dopamine. And we have to replace all of the dopamine with the medication. So whether the medicine lasts 90 minutes or 4 hours or 6 hours is going to make a huge difference to you, because that's when you're going to have your off periods, is whenever that levodopa is metabolized and used up. So we want to use a longer acting form of levodopa so you don't notice these peaks and troughs. And every time you trough, that's an off. That means that your motor symptoms of PD come back, the tremor, the rigidity, the freezing of gait, that shuffling gait. And so that's the reason why initially you don't notice those off periods, and it takes several years. And then you start saying, oh yeah, now I know what they were talking about in the support group when they're talking about off, or that I ate a hamburger and my pills didn't work. And so that's why initially you don't notice it. That's sort of your savings account and your checking account of levodopa. And of course, anybody who has a checking account, who ever got a paycheck, you much rather get a bigger paycheck than a smaller paycheck, because that bigger paycheck is going to cover more expenses throughout the month. And that's what we want to do with levodopa. So that's why it's worth it to try and fight the insurance company and get the longest acting form of levodopa that you can get your hands on, so that you don't have to peak and trough so many times during the day. Every time you trough, you go off, and then we have to wait. And we don't know, because that gut doesn't really work the way it's supposed to. We don't have any predictability. Am I going to swallow that pill, and is it going to kick in 30 minutes, or is it going to kick in an hour or 2 hours, or not at all? And so the less times we have to trough and go off, the less of that unpredictability that we're going to have. So we're all excited about IPX203. You were excited to get a longer acting form of levodopa. So it's much easier to take a pill only 3 times a day instead of 5 or 6 times a day. And then we add in these once a day adjunct medicines to make life a little bit easier. So our whole job is to put you guys back in the driver's seat, to give you guys control over the disease, not the other way around, and that you're not planning your day around every single dose of levodopa, that your day is more predictable, so that you're not thinking, gosh, when I swallow this pill, when is it going to kick in and how long it's going to last? Well, the longer we have per dose, the less of those transitions you're going to have, the more better on time, better quality of life you're going to have. What else?
That was a great analogy, the checking and savings account.
Right.
So we're going to pivot a little bit. Somebody asked, are there specific tactics you recommend to avoid dementia? And are there some Parkinson's meds that are linked to a higher dementia risk?
Yeah, so none of the PD meds are linked to higher dementia risk, but remember that Parkinson's has motor symptoms, so the tremor, the stiffness, rigidity, the bradykinesia, or slowness of movement, and your trouble with gait and balance. And your medicines, all the PD medicines make the motor symptoms of PD better, but they make non-motor symptoms of PD worse. So non-motor symptoms are a low blood pressure. So some patients get dizzy when they stand up, constipation, anxiety or depression, cognitive issues like mild cognitive impairment or dementia. So your medicines can cause confusion, they can cause hallucinations, they can cause compulsive behavior. So our job is to always get that balance just right, that you have enough meds on board, that you're mobile, but not so much that every time you stand up, you faint, or that you're hallucinating, or that you're up all night doing one-click shopping on Amazon. So once you become demented, then you don't tolerate the PD medicines as well. We run into more trouble with hallucinations and confusions. And later on, if the patient has more dementia, then we have to give up some mobility. Some mobility to keep the mind as clear as possible. And so how do we prevent dementia? So right now, all of the medicines and all the therapies for PD, whether they're medical things like pills or surgical interventions like DBS or deep brain stimulation, they're purely symptomatic. They don't stop or reverse the disease. They only treat the symptoms. And of those, they only treat the motor symptoms, and they make those non-motor symptoms worse. So we think that aerobic exercise, so the one that gets the heart rate up, makes those little neurons that still make dopamine and makes them make new connections. The more connected they are, the more robust and healthy they are, the longer they live, the slower the progression of the disease. So remember that you came into the neurologist's office that with that 40% savings account, those are those neurons that produce dopamine. So we want to keep them living as long as possible. And the only way that we currently know how to do that is for exercise, for the patients to exercise. And just like you want a well-balanced diet, you want to have a well-balanced exercise program so that you have aerobic exercise for the brain and you have resistance training for the muscles and the bones. So remember, you have bradykinesia, slowness of movement. It's the reason why they have you walk down the hallway every time you go visit the neurologist. And we see that you're not swinging your arm. So there's nothing physically wrong with the arm, the muscles or the bones in the arm. It's just the message from the brain to the arm is too slow and it's bradykinetic. And so, but if the muscles stop moving, they start to atrophy and waste away. And once the muscles stop pushing and pulling on the bone doesn't absorb any more calcium. So we want resistance training to keep those muscles toned and healthy and still moving, so that when you do your physical therapy, that these quadriceps that get you in and out of a chair or in and out of bed are still strong enough to do that. And then once the muscles start to push and pull on the bones, that's how the bones absorb the calcium from your diet or your supplement and deposit it in the bone. If the bones aren't getting any pushing and pulling from the muscles, they start to leach that calcium because it's very expensive. So that's why you see the astronauts on the space station, they're always doing forced exercise. They're like little hamsters on the treadmill. And because they're in zero gravity, they are becoming osteopenic. They're losing calcium. And when they get back to Earth, they have very weak bones. So they have to do forced exercise. Same thing happens for a PD patient. So it doesn't matter if you're just popping that calcium and you're just sitting on the couch, you're just excreting that calcium in your urine, just expensive urine doing nothing. So we want to do exercise, resistance training to keep those muscles and bones strong, and aerobic exercise to keep those neurons that produce not only dopamine, but everything else in there, keep it living as long as possible. And the whole point of like tweaking your meds and adding these new meds and having more on time per your dose is to allow you to exercise, to allow you to use that body and do what you want with it. And we always want you to do exercise first over everything else. But that's the whole point. If you're off, if your meds aren't working and you're stiff and rigid, it doesn't matter if you have a treadmill at home if you can't get on it and walk because you're too bradykinetic. So the whole reason for taking these medicines is to allow you to exercise and keep that brain as young and healthy as possible.
Thank you. And now a couple of questions about dyskinesia. Can anything be done? Someone asked if the pump has worked for people with dyskinesia. What can be done?
Yeah, so think of it, so that therapy, we call this the therapeutic window. So the therapeutic window is that part of the day that you're on, that you take the medicines and they're working. Everything's working and you don't have any involuntary movements. And that window gets smaller and smaller as the disease progresses because you make less and less of your own dopamine. And so when all the dopamine comes from the medication, remember, then that window becomes 90 minutes long. It's very, very small. And so either you peak above it, and that means on time with dyskinesia or on time with involuntary movements, or you're trough below it and you're off. And so then it can take a long time to get back on. And so our job is to try to keep you within that therapeutic window as long as we can, and to keep you from peaking and troughing above and below that as many times or as few times during the day as possible. So how do we do that? We use long-acting forms of levodopa, such as Rytary or IPX203, which hopefully will be approved later on this month. Then when patients are taking IPX203 or Rytary more than 4 or 5 times a day, we start to consider a pump. So right now we have Duopa, which is a gel infusion of levodopa that requires a little medication port that goes straight into the tummy, and that has a little pigtail that goes into the small intestine, exactly where that little elevator is where your levodopa gets absorbed. So it's always first in line to be absorbed and get up into the brain. So it's not so critical of what you eat and when you eat. You're still going to notice those offs, but it's not going to be as deep as if somebody was taking a pill. So that's the current form of the pump that we have is Duopa, which is a gel form of levodopa requiring a PEG-J or the medication port. And then next year in 2024, hopefully 2 new pumps will be approved, and they'll be subcutaneous pumps. So they won't require the medication port that goes into the tummy. It'll be subcutaneous. So if anybody has seen a patient with an insulin pump, a type 1 diabetic who uses an insulin pump, it's like a little Band-Aid with a little cannula that goes into the skin. And you infuse the levodopa that way. The other pump will be apomorphine, so that's a dopamine agonist. And the nice thing about the pumps is that we can give you a continuous infusion over the 24-hour period. Apomorphine will just be 16 hours during the day. And currently Duopa is just approved for 16 hours during the day. But the nice thing is that it's continuous infusion. It doesn't peak and trough like you do with oral medications. So you still have some off periods, but you have much more control over your dose with a pump than with a pill. Because think about, when you swallow a pill, once it's down that gullet, you can't get it back. And once it's down into the tummy, we don't know when it's going to transition into the small intestine and when it's going to kick in and how long it's going to last. But if you're on an infusion pump, then I can go up on the pump. If you need more, like let's say you had a hamburger for lunch, I can give you there's an extra dose button on all of the pumps. So you can give yourself an extra dose and get yourself back into that on position out of that trough. Or if let's say you got too many extra doses and you had on time with dyskinesia, meaning that you went above your therapeutic window, now you're on, you can move, you're mobile, but now you have extra movements and you don't really like extra movements. Those dyskinetic movements can not only be socially embarrassing, people look at you at church or at dinner and so you don't want to go, but they're physically disabling too. So if I'm trying to eat and my arms are all over the place, it's hard to do my activities of daily living. So I want to give you on time without dyskinesia. And with the pump, so if you're dyskinetic with a pill, basically we have to wait until that pill is metabolized for that dyskinesia to go away. And if you're on Rytary, we're going to have to wait 4 hours for that to happen. So with the pump, all I have to do is turn your pump down or turn it off for 20 minutes. The dyskinesia goes down and then I turn it back on. So you have much more control over your disease with a pump than you do with oral medicines. And now that we're going to get all of these other options, basically anybody who takes pills that more than 4 times a day would be offered a pump. And so then you would decide, yes. And always we want to make sure of any therapy, do the benefits of the medicine or therapy outweigh the side effects of the therapy? So right now with the PEG-J, because not that many people know patients who have Duopa, they know way more patients who've had DBS in their support group, and they're not too, excited about the PEG-J. Many patients, even though they're good candidates for the pump, they say, no, I rather take levodopa 6 or 7 times a day, or I rather go to DBS or deep brain stimulation. But as the clinician, we would always choose the therapy that's less invasive and reversible first before we would do something like deep brain stimulation. But you guys in the clinic are still choosing DBS first. So hopefully that will change as the SubQ pumps will come out. And it'll be much easier to try the pumps because we don't have to do any kind of surgical procedure. We can try the pump. If you like it, great, we keep it. If not, we can always go back to oral pills. And then the other question was about dyskinetic movement. So if you become dyskinetic, then we fractionate your levodopa. We can either take it closer together and smaller doses, although we don't like to do that because we have longer acting forms of medicines than the pumps now, but that's what we used to do. And then we add medicines like amantadine or Gocovri, which allow us to have more on time without the dyskinetic or wiggly movements.
I had a couple of questions also about, one person asked if you could explain the difference between the dyskinesia and dystonia, and someone asked if you could please explain some treatments for dystonia.
Yeah, so dyskinesia means involuntary movements. And so let's sort of go through the movements in Parkinson's disease. So usually in Parkinson's disease, you have bradykinesia, slowness of movement. So if the patient doesn't take any medicine, they're bradykinetic. They're very slow, stiff, and rigid. Once we give you medicine, because those dopamine receptors aren't working the way they should, sometimes it overshoots and you get extra or involuntary movements. And so dyskinesia means random involuntary movements. So how we sort of teach medical students of how to differentiate a tremor versus a dyskinetic movement. So the tremor is a fast and rhythmic movement. Usually you see it in the hand or the foot or the chin in Parkinson's disease. So we tell medical students, if you can predict the next movement, that's a tremor. So if I know that always your chin tremor is going to go like this, then that's a tremor. If you have dyskinetic movements, they can be all over in the Parkinson's, they're all over the body, the extremities. You can see them in the mouth. So if your tongue is kind of darting back and forth and it's all over the place, and I can't predict the next movement, that's a dyskinetic movement or choreiform movement. If your tongue is rhythmic and fast, that's a tremor. So tremor happens because you're off. Dyskinesia usually happens because you peak above your therapeutic window. So that's called peak dose dyskinetic movements, too much medicine. But because PD is more complicated, you can also have off period or diphasic dyskinesia. So as your medicine is wearing off, then not only can you have tremor, but you can have dyskinetic movements at the same time. And so that's why your doctor has that 24-hour sheet, and we map out what time you're taking the medicines and when you're having your symptoms. And that helps me differentiate, is this peak dose dyskinesia or diphasic dyskinesia? And the fix for that is different. And dystonia means an abnormal contraction of a muscle. So the muscle contracts and it stays stiff and rigid and it can't relax. And in Parkinson's disease, morning dystonia is super common. So you take your medicines throughout the day, and then at night you don't take any medicines. And when you wake up, your gas tank is empty. There isn't any medicine, any levodopa, any gas in the tank in the morning. So you're off and you're dystonic. So usually patients notice that their foot, it turns in, that big toe goes up, the other toes curl under. So that's kind of a dystonic foot. And that when you take your medicine, it kind of relaxes and melts away. So many times we figure out, is it a morning dystonia? Is it a fact that your gas tank is empty? Then we either add medicines at night or once a day medicine so that you wake up with some gas in the tank. The other thing that we can do when you have off periods to bypass the gut is we use on-demand therapies that bypass the gut. So we can use an inhaled form of levodopa that goes lungs to brain. So we don't have to worry about that pill getting stuck in the stomach. And that way you kick in 5 to 10 minutes and it lasts about an hour. And you can take all of those on-demand therapies up to 5 times a day. There's also a sublingual apomorphine, although that's going to go off the market later this year. And then there's apomorphine as an injection. that's the most fast and reliable form of an on-demand therapy. And again, it kicks in 5 to 10 minutes and lasts about an hour, and you can take it up to 5 times a day. So that would be one way to get you back into that therapeutic window quickly and not have to be worried about that pill kicking in. So many times in the morning, their patients take their first dose of Rytary and an on-demand therapy first thing in the morning, so that on-demand therapy is working to melt away that dystonia before that pill starts to kick in. And so you're on a little bit faster during the day. You're not waiting around an hour or two to get dressed and bathe. And all of the pumps have an on-demand therapy, an extra dose button built into them, so that you have that on-demand therapy as part of your infusion. So another reason why we like to use the pumps. So dystonia means an abnormal contraction of a muscle. So if you have it in the neck, and many times it doesn't respond to levodopa, we can inject your neck muscles with Botox and then get you back midline if your face and your head and neck are stuck on one side. You can have something called eyelid apraxia, where the eyelids close and you have to physically use your finger to open the eyelids. That's a form of dystonia as well. And we can use some Botox to keep those eyelids from always shutting. So we use Botox, and then we use on-demand therapy to treat dystonia, and then just increase your on time overall to help the dystonia. And for the dyskinesia, depending on whether it's peak dose or diphasic, too much or too little, basically we just use longer acting forms of the medicine and kind of smooth out those peaks and troughs. So you spend most of the day in that therapeutic window and you're not peaking above it or troughing below it.
Now, somebody did ask, can you comment on the origin of the stooping posture in Parkinson's, and is it possible to avoid it from happening?
Yeah, so the stooping posture is part of the bradykinesia. So patients who are untreated, so they become slow, stiff, and rigid. They have a shuffling gait, so a small stride length. They are not swinging one of the arms, or many times if you've had it more than 3 or 4 years, both arms aren't swinging, and you develop a stoop posture. So you kind of start to curve over. And it's just part of the bradykinesia and that rigidity and stiffness that happens in the muscles. And so we like to do lots of physical therapy to keep your posture up straight. And once we have better posture, we're not going to have as many falls because your center of gravity is where it should be. With better posture, we're going to have better speech and swallowing as well. So if you're stooped over, it's hard to take bites and swallow and have it go down the right pipe. And the same thing, if you have a stoop posture, that diaphragm, which bellows the lungs, doesn't work efficiently. And so you can't take deep breaths in and out. So you develop a hypophonic or whispery voice. So with better posture, that diaphragm is going to work better, but bellow the lungs better, so you can take a deep breath in and then expel it and have a nice strong voice that projects out farther and louder. So that stoop posture is part of PD, and the better treated your Parkinson's is, the more physical therapy you have, the better posture, gait, and balance you're going to have.
Somebody asked, and I've heard people talk about this in in-person programs, can we take a few moments to talk about the vision problems from Parkinson's? He's plagued with vision issues, is seen a neuro-ophthalmologist, but I've had people talk about like the double vision in programs. So can we talk a little bit about vision in Parkinson's?
Yep. So remember that you have bradykinesia, slowness of movement, and that affects all of the muscles of the body. So just like it affects your gut and you develop constipation, it affects the muscles of the eye. So your eyes use muscles for different things. So they move the eyeballs back and forth. And if the eyeballs are too slow, if one side is a little bit slower than the other, then you see that as double vision. So you see 2 TVs or 2 books. And then the other thing is that your lens is also controlled by muscles. And the lens is what allows you to read and see near and far. So many patients will notice that accommodation, that means that the lens, gets thicker and thinner. So they're at the restaurant, they're looking around the restaurant, and now they're going to read the menu. It takes a little bit longer for them to focus on the menu because the accommodation, that lens, the muscles that make the lens thick or thin, it's just slower, it's bradykinetic. So that is just a matter of waiting. Eventually you'll accommodate and you can read the menu, and then you can look at the restaurant again. And then if you have diplopia or double vision, because your eyes are not congruent, they're a little bit off kilter. Remember that PD is asymmetric. So the symptoms start on one side and then move over to the other side. So one eyeball is always a little bit slower than the other. And then so the neuro-ophthalmologist can put some prisms in your lenses to try to bring that back into kilter so that you have less double vision when you watch TV or you read a book. The other thing that you notice in PD and vision is that the retina has dopamine in it. Those retina cells have dopamine. So that's why your night vision is not as crisp and clear as it used to be. And your contrast vision is not as good as it used to be. So many patients develop trouble driving at night, first because of the lack of, a little bit of night blindness. And then that retina it doesn't have enough dopamine. So that's the other thing that you notice with PD, and that we just have to, use your levodopa and do the best that we can.
This is honestly one of my favorite questions, because I remember people asking it of Terry, who I used to work with, and they would say, basically, how do I know if my medication is working? And she would just say, you should feel better. And someone did ask, how do you best determine or measure if you're responding to the levodopa?
Yes, remember, initially, patients will say, yeah, I take my levodopa, but if I forget that noon dose or if I'm late, I don't really notice. And so they're still in that honeymoon period. You still have your little savings account of dopamine that's still taking all those overdrafts from your levodopa pills. And as that savings account starts to be exhausted and all of your dopamine comes from your medication, then you start to notice your off periods. And off periods means that your motor symptoms and non-motor symptoms of PD come back. So you have to learn how to read your body, and remember that there's motor and non-motor. So your motor are things like tremor and rigidity, but many times before that tremor in that hand comes back when the medicine is off, many times your non-motor symptoms of PD come back first. So some patients have what they call the willies or some anxiety or a frank panic attack before the motor symptoms come. And so it's important to you to learn how to read your body and then to dose it. So let's say you're on a schedule of 8, 12, 4, and 8. But you went to rock steady boxing, or you went to physical therapy, or you had to go to see the accountant because they screwed up your taxes, and you used up your levodopa faster. It didn't last the 4 hours. It wore off at 11. So at 11, you start to have the willies, and at 11:30, you start to have the tremor, but you waited. You're like, oh no, my doctor said 8, 12, 4, and 8. So you waited until 12 to take that dose. So what's happened now, your gut's totally slowed down. I've swallowed the pill into a gut that's not working, that's slow. So now instead of that pill kicking in 30 minutes, which would have happened if I had taken it at 11 when I first felt the willies, then it's going to take an hour for that pill to kick in. So I took it at 12, it didn't kick in until 1. Then I only got 2 or 3 hours of on time. So we want to learn how to read your body, and you take the dose when your body needs it. Remember, your body has Parkinson's disease, not the clock. And your levodopa, it's like gas in the car. So if you drive your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. And that's why you notice, gosh, every day is different. Some days my medicine lasts 4 hours, sometimes 5 hours, and some days it only lasts 3 hours. And that all depends on what you're demanding of your body. Did you send that body to rock steady boxing, to physical therapy, to go talk to the accountant, or was that body just watching Netflix all morning? And so that's why every day is different. And so the more that you learn how to read your body, you can adjust the medicine accordingly. Again, one more reason why your doctor wants once-a-day medicines and longer acting forms of the medicine, so that we have a little bit more leeway depending on what's going on. So if you went to physical therapy, we're not going to run out of that medicine so quickly. The same thing with a pump. We just have much more control over your dose and more on time per dose with longer acting and once a day medicines than taking it every 3 or 4 hours. So we don't want to chop up your day and always be falling into these off periods. And then what ends up happening is that you end up planning your day around every single dose of levodopa. And when you start to do that, you stop doing stuff because you don't have any predictability in your day. You're like, oh, I never know when it's going to kick in and how long it's going to last. So I'd rather not go play golf with my friends or go out to brunch with my friends because, what if I eat brunch and then nothing works and I can't walk out? So that's sort of why we push these longer acting forms of medicines, and we're excited for the pumps to come out so that you're not noticing all of these off periods so often.
Someone asked if you could discuss the difference between classical Parkinson's and like a Parkinsonism, like multi-symptom atrophy.
Yeah, so there's Parkinson's disease and Parkinson plus syndromes. So think of it, there's cells in the body that are dying off. And it depends which cell dies off. Is it think of it, there's a pitcher and a catcher. So if the pitcher dies off and I can replace your dopamine, that catcher is still there to catch the dopamine. So when I give you levodopa, the catcher's still there and everything works. So that's idiopathic Parkinson's disease, sort of classic Parkinson's disease. The patient is bradykinetic. They all look the same initially, slow, stiff, and rigid, that stoop posture, that's, small stride length. And so if you give the patient levodopa and they get better, that catcher is there to use the medicine, then we call that Parkinson's disease. If we give you medicine and you don't get better, meaning the pitcher is still there, but the catcher is gone, it doesn't matter how much levodopa I give you, the catcher is not there to catch it, it doesn't work. So I give the patient levodopa, nothing happens, they're still slow, stiff, and rigid, they still look Parkinsonian. Then we call that a Parkinson plus syndrome. And of those, there's MSA or multi-system atrophy, there's PSP and CBGD, and they all look the same initially. And then 5 years into their diseases, they all develop their different things. So MSA has more autonomic features like low blood pressure and bladder issues. Lewy body dementia has dementia as part of its main features. PSP has the eye movement, so you can't look up or down, your eyes kind of lock up. And CBGD, you develop sort of an alien hand syndrome. So initially, those Parkinson plus syndromes all look the same, and we're not able to say which one it is until 4 to 5 years into the disease. But the difference is that one responds to levodopa and the other one doesn't, or the cousins of Parkinson's don't respond to levodopa because it's the catcher that's gone. And then you can have something called drug-induced Parkinsonism. So you're blocking dopamine in the brain by using dopamine blocking agents, so things like antipsychotics. And so those patients look Parkinsonian because we've blocked dopamine in the brain. So they're slow, stiff, and rigid. They could have a resting tremor, a shuffling gait. But the cells are still there. So when we image the cells with a DAT scan, we can still see them light up. And when we take away the dopamine blocking agent, the patient gets better. So that's why when you come into the office, we give you a list of meds not to take. The most common medicines on that list of medicines not to take are antipsychotics or nausea medicines that block dopamine. So you can have, and that's called a drug-induced Parkinsonism. And it's one of probably the most common reasons people do a DAT scan or a dopamine transporter scan to look at, are the pitcher and catcher missing, or they're still there, we just block them with medicine.
I have a few medication questions. Someone asked, is there a skin patch?
So there is a patch for Parkinson's. It's called Nupro or retigatin. So that's part of a dopamine agonist. So think of levodopa turns into dopamine in the brain, exactly the same chemical that's missing. The dopamine agonists, those are medicines like Nupro or retigatin, Mirapex or Pramipexole, or Requip or Ropinirole. They go in, they sit on the same receptors as dopamine, but chemically they're not the same chemical. The pluses are that there's once-a-day versions of all the dopamine agonists, and the patch goes through the skin, so we have less trouble with nausea and vomiting with that medicine than we do with the pills. But short-term, we have more side effects like excessive daytime sleepiness, compulsive behavior is quite common at high doses of dopamine agonists, hallucinations. So today, with longer acting forms of levodopa with pumps, we actually use a lot lower doses of dopamine agonists. So now I would say that my doses of dopamine agonist in patients are more like a restless leg dose rather than a full Parkinson's dose, because they're very dirty drugs as far as compulsive disorders and hallucinations, orthostatic blood pressure. So you use much lower doses of those. But we like them because it's once a day. So remember that somebody had to ask the question about morning dystonia, waking up without any gas in the tank. It was nice to use those once a day dopamine agonists so that you could wake up with a little bit of gas in the tank the next morning.
Somebody wants to know, will there be a replacement for the sublingual Apokyn, or they're just going to keep the injectable?
Yep, so they're just going to have the injectable. So Synovian has dropped the drug, and I don't think anybody's going to pick it up. So you'll have the injectable. It's called Apokyn. It's very reliable. So the patients don't like it as much because it has a needle, but it's, very reliable. It's fast, easy, and it kicks in about 5 minutes, and you can take it up to 5 times a day. And it's apomorphine, so it's a dopamine agonist, the same kind of medicine as Mirapex, Requip, or Nupro. And it'll be the same medicine that'll be in one of the SubQ pumps that comes out next year, the apomorphine pump. So for those patients, we can use that Apokyn also as an on-demand therapy. Ambrosia is the inhaled form of levodopa. I think that will stick around for a long time. Hopefully there's no plans for them to get rid of that. The other thing is that Ongentys will be no longer marketed in the US by all the Portuguese company after December of this year, but we'll still be able to get it out of Canada. So that's the COMT inhibitor that's just once a day.
Somebody asked, because we did touch on it, what is an agonist? And then somebody asked if you could explain how the levodopa reacts with, for example, pramipexole, which is an agonist.
Yep. So we use all of them together. So, many times our patients end up on polypharmacy because we're trying to stretch out that on time as long as possible. So that's why you end up on levodopa, whether it's Sinemet or Rytary. You end up on a dopamine agonist like Nupro or Mirapex. Then you end up on Ongentys to make that levodopa last longer, and you end up on Rosagiline, another medicine that makes your dopamine last longer. And then you develop dyskinesia, so then we add Gocovri. So now you're on 4 or 5 medicines for Parkinson's disease, all of which are very expensive if they're all branded medicines. So remember, always want to make sure do the benefits of the medicine outweigh the side effects of the medicine, including to your pocketbook. So one of the reasons that we move on to a pump is that we want to go back to monotherapy. We can use all of these medicines together, but remember, the medicines they make your motor symptoms better, but they make non-motor symptoms worse. So every time I add in a new medicine, I'm going to lower your blood pressure. I'm going to increase the risk of hallucinations or compulsive behavior or excessive daytime sleepiness. And I want to minimize that. And I don't want to be spending $200 a month on every single medicine. So by going back to a pump, we can get rid of a lot of these medicines because we don't need a lot of these extenders. You're already in a continuous infusion. So I don't need so much, medicines that make it last longer. And then usually if you don't have restless legs, then we don't need to use a dopamine agonist. And we don't need to use Gocovri if you're not having a lot of peak dose dyskinesia. So that's one reason to consider DBS and consider a pump, is to go back to monotherapy or the least amount of medicines that gets the job done. But you can certainly use them all together. And there's patients who are on 6 different Parkinson's medicines.
Somebody did ask, as you're talking about the pump, the SubQ pump is new, so how effective is it?
So it's very effective. So the only thing, remember, there's no free lunch. So with the current pump, you need a PEG-J, so you need the medication port. So although it's very effective, we have to manage the pump, we have to clean the tube, and if it falls out, we have to put it back in. The SubQ pump, because it's going through the skin, in the clinical trials, about 20% of the patients develop some allergic or skin reaction to the levodopa or the apomorphine. So some people can push through that and be like, I don't care if I have granulomas, I just kind of rub them out. And if it's a little bit red or irritated, I'd rather be on most of the day. And if you don't develop that, then, it's a pretty good therapy because you don't peak and trough every 3 hours like you do with a medication. But there is a subset of patients who have an allergic reaction to the medication. And it's either something that you can live with, sort of like a red irritation that goes away after 2 or 3 days, or if it's something that you find super uncomfortable, then we would go back to the oral medicines. But there's no, so the normal brain gives you a continuous infusion of levodopa or of dopamine over the 24-hour period. It doesn't pulse you with dopamine every 2 or 3 hours. And we want to get therapy to that point. We want the therapy to work like your normal brain. And all of the disability that PD patients have is that pulsatile frequency of dopamine that gives you on and offs, peak and trough all day long, that interrupts your day, that doesn't give you predictability over your day. And our job is to go back to your old body where you had control over the old body. It was predictable. And when I needed to use the body, I know I could use it. It wasn't just off. And so we want to get back to that.
Do you have another question about the hallucinations? Does it always lead to Parkinson's psychosis, or can it just be related to the meds and how your fluctuations are going that day?
Yep, it can be related to the meds. So the higher the dose of whether it's levodopa or any of your other medications, the more dopamine you have in the brain, the more you can hallucinate. So your brain just becomes more sort of artistic. So it makes shapes it makes things, images out of shapes. So if you have a cushion on your sofa and it has shapes, it'll make it into a form or a person. So the more dopamine you have, the more creative that brain is, the more it's going to see stuff in the environment. And then one way to minimize that is to, get rid of curtains with lots of patterns, cushions with lots of patterns, and then use the lowest dose of medicine that's needed. But it doesn't always lead. But if you develop dementia, then your brain just isn't as good at dealing with these high doses of dopamine. And we push you over the edge as far as confusion, hallucinations a little bit sooner.
Now, this is something I've heard. Someone asked if the honeymoon is 5 years, but you were diagnosed, say, 2 years ago, but probably had Parkinson's before you were diagnosed. When does the countdown begin of those 5 years? How do you decide,
so your countdown begins with your motor symptoms. So you've got those 10 or 15 years before you saw the doctor, before you develop Parkinson's disease. That's things like constipation, anosmia or losing your sense of smell, a history of anxiety or depression. So what happens is that you notice that you're not able to multitask as well. Emotionally, you're not as resilient as you used to be, that fuse gets shorter. And so that's sort of like the anxiety and depression. And then when we give you, it's not only dopamine that's low. When dopamine is low, it makes serotonin, norepinephrine low. When that serotonin is low, it makes you more irritable. The fuse is shorter and you're not as emotionally resilient as you once were. So if you go to the airport and American Airlines canceled your flight, 10 years ago, you'd be like, okay, fine, I'll just go to Southwest and book another flight. When you have Parkinson's, that seems like an overwhelming task. How am I going to get through this kind of thing? And then the other thing that happens in your premotor phase is something called RBD, or REM sleep behavior disorder. So usually when you go to sleep and you go to REM sleep, which is your dream sleep, usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis doesn't take place. And so during REM, when you're dreaming, you act out your dreams because you're no longer paralyzed. So you can talk, yell, scream, kick, and punch because you're acting out your dreams. And it turns out that during REM, your brain is practicing getting away from a threat. And so that's why these dreams are always so violent and there's always all that carrying on. That's true for both men and women. And so that's called RBD, or REM sleep behavior disorder. So we know that patients with RBD, 80% of them develop a synucleopathy. That's that misfolded protein that we see in Parkinson's disease. And the most common synucleopathy is Parkinson's disease. So to answer the question, the clock for your savings account starts with the motor symptoms, not your RBD or your constipation. It starts with the rigidity, the stiffness, and if you have a tremor, with the tremor. So remember that you want to exercise as much as possible to keep those neurons living as long as possible and keep that savings account going as long as possible.
Asked if you could comment on some Parkinson's issues but that the mouth is affected by, whether it be dry mouth or the drooling or the loss of taste buds and stuff. If you could talk a little bit about that.
So remember that you develop anosmia, or lack of a sense of smell, and without smell, you don't have taste and you're left with sweet and sour. And that's why PD patients develop a sweet tooth, because everything else kind of tastes like cardboard. You actually produce less saliva especially with the medications that you take, but it tends to drool out. So remember, you have bradykinesia, slowness of movement. So just like you don't blink as often as you used to, and your eyes don't move in conjunction as easily as they used to, and you develop double vision and dry or itchy eyes, because you don't swallow as often as you used to, then the saliva tends to pool in and drool out. And so that's the drooling. So how do we treat that? We can use sugarless candy or suck on a hard candy to automatically get you to swallow and take care of the drooling that way. If that doesn't work, then we can inject your submandibular glands with myoblock or a Botox and shut them down so they don't produce saliva. And those injections you get every 3 months. But what can happen there is that then the parotid say, hey, those submandibular glands are getting kind of lazy. I'm going to make more saliva. And so sometimes it backfires on us. But those are the 2 ways that we can treat. We don't like to use things like atropine that kind of dries you out, because that also causes urinary retention and cognitive impairment. So we tend to stay away from that, but that can be another treatment for the drooling. But I usually start with some hard candy, sugarless gum, and then we go to myoblock. And so so that's the dry mouth. And then of course, dry mouth is made worse by all of the other medicines that you're on, not only your PD medicines, but bladder medicines and all, all those other things. And then swallowing is also affected by that bradykinesia. So there's about 23 muscles that are involved in the swallowing. And if they're too slow, that little flap, remember, you've got one tube and one part of it goes into the lungs and the other one goes into the esophagus, into the stomach, and it's closed off by a little flap. And if that flap is too slow and something gets stuck in there, we call that choking. If something gets through in there, we call that aspiration, and it can cause a pneumonia and infection. So that's why we'll send you to speech therapy. That's why we'll order swallow studies to make sure that all of the food is going down the right pipe. And then when we start to see that it's slowed down or you have trouble with certain foods, then we move on to a soft mechanical diet or things that are easier to swallow. So the first thing that happens, you have trouble with pills, especially like your calcium and magnesium pills. So either cut them in half or crush them. We put them in a little spoonful of yogurt or applesauce and take it that way. And that way it's easier to swallow. And then don't put it just in the yogurt, because then you have to eat the whole yogurt to get the full dose. So just put it in a spoonful of yogurt and take it that way. And then we start to modify your diet so it makes it less likely that you're going to aspirate your food or choke on it. And we want small little bites. You chew it up really, really well. You alternate liquids and solids, so you're always washing it down. Always eat sitting upright and no talking while eating. That way that flap doesn't get stuck, and that way you minimize your aspiration risk.
We are basically out of time. Can I ask one more question? Sure. So somebody had asked, and it's the truth, is that getting old comes with many symptoms. Yep. So how do I determine if it's Parkinson's or just getting old?
Yep, so that's a super common question. So the way to tell between PD and TMB, too many birthdays, is if your symptoms, they wax and wane with your medication. So with your on and off period. So many times you can have back pain, you can have Charlie horses, cramping, and all of those symptoms are going to wax and wane with your medication. Same thing with paresthesias or numbness and tingling in the feet. So if your numbness and tingling, they wax and wane with your medicine. So as the medicine wears off, your symptoms come back. That's Parkinson's disease. If your feet are always numb and tingling, then that's neuropathy from diabetes or another reason. So if your symptoms are always there, that back pain is always there, that sciatica is always there, then it's arthritis or TMB. If it waxes and wanes with your medication, it's the Parkinson's disease. Remember, TMB, it's chronic and progressive too, but better than the alternative.
Well, thank you so much. This was incredible. We could probably be here for another hour, but we're going to be respectful of your time. So thank you so much. As always, we have a tradition here at PMD Alliance, our wave of gratitude. Thank you so much, everybody, for spending your Monday with us, for your amazing questions. And of course, thank you to Dr. Ospina for taking the time to chat with us today.
It's always a lot of fun, and you guys have great questions.